Hello and welcome to the self-learning module on understanding ECGs. My name is Mukesh Bhargava and I'll be guiding you through the intricacies of electrocardiograms today. This is a basic course. Before we dive in, let's set some objectives for this presentation. By the end of this module, you should be able to recognize the basic components of the ECG wave, identify common arrhythmias and abnormalities. The ECG or electrocardiogram is an invaluable tool in medical practice, particularly in cardiovascular medicine. It provides real-time insight into electrical activities of the heart, helping us diagnose a variety of conditions ranging from arrhythmias to ischemia and heart attacks. The self-learning module is designed for IM care and heart care team. However, anyone interested in the subject is welcome to learn. This module is designed to be self-paced. Feel free to pause, rewind, and revisit any part of this presentation as needed. Let us begin with focus on one of the most crucial parts of understanding the ECG, the PQRST complex. The PQRST complex can be broadly broken down into 9 parts. There are 3 intervals, the PR interval, the QRS duration, and the QT interval. There are 3 smooth waves, the P wave, the T wave, and the U wave. There are 2 segments, the PR segment and the ST segment. And then there is the one QRS complex, which is composed of 3 pointy waves, the Q wave, the R wave, and the S wave. That is about it to the PQRST complex. First up is the P wave. The P wave represents the depolarization of the atrium, which is basically the electrical event that triggers the atrial muscles to contract. In simpler terms, this is when the top chambers of our heart squeeze to push the blood to the lower chambers or the ventricles. A normal P wave is smooth and rounded as shown in the figure. The P wave has its upper size of normal and the shape as you see. The P wave becomes chaotic in atrial rhythm disturbances like atrial fibrillation and flutter. The P wave loses its connection with QRS complex in heart blocks. So when you start looking at an ECG, start by looking at identifying the P wave. If you do not see the P wave, the rhythm is likely not originating in the atrium. Examples could be a junctional rhythm. If the P wave is pointy and like the peak of a mountain, it is likely due to right atrial enlargement, commonly seen in patients with significant COPD. If the P wave is broad and notched and like a stretched out lowercase m, it is called P mitral and is due to left atrial enlargement, commonly seen in mitral stenosis. So in summary, the little P wave can tell you a lot about the atrium, and it does not tell you much about blocked arteries and the heart muscle. Following the P wave, we have the PR interval as highlighted on this slide. This starts at the beginning of the P wave and ends at the beginning of the QRS complex. It represents the time the electrical impulse takes to travel from the atria down to the ventricles. The PR interval is an indicator of AV node function. If there is a P wave and there is a QRS complex, there will always be a PR interval. The normal PR interval is between 3 to 5 small boxes, which is 120 to 200 milliseconds on a standard speed ECG. The abnormalities of the PR interval could be that the PR interval is too short, it is too long, or it is variable. That is the most common abnormality in the PR interval. Now, there can also be PR elevation or depression, but we will leave that for the advanced course. Next comes the QRS complex. This is the most striking part of the ECG wave, and at times our attention goes directly to it. It represents the depolarization of the ventricles. It is highlighted on this slide. Or in simple terms, the depolarization means that this is when the lower chambers of the heart, the ventricles, pump blood to the rest of the body. It is a very quick event. It typically lasts from 80 to 120 milliseconds, which on the ECG is evident by the QRS duration of 2 to 3 small boxes. The QRS complex changes if the depolarization of the ventricle changes, common reasons being left or right bundle branch block. Now the bundle branch block may be complete or incomplete bundle branch block. A scar from old myocardial infarction can cause deep Q waves in particular leads, changing how the QRS complex looks. Also, based on the height of the R and the S waves in different leads, we can detect whether the right or the left ventricle is hypertrophied or enlarged. So to sum it up, the PQRST complex is an ECG waveform that can tell us about the ventricles, how they depolarize, is there a scar, are they enlarged, and helps us in identifying a fair number of cardiac conditions. Next up, after the QRS complex, we turn our attention to the ST segment. This is the horizontal or flat line that follows the QRS complex and precedes the T wave. It is on the same level as the PR segment. Movements in ST segment are usually caused by ischemia or infarction. If there is ST elevation, that signifies acute injury. If there's ST depression, that signifies ischemia. These may also be changed over a longer period of time if there is an aneurysm, which will cause a persistent ST elevation. Left ventricular hypertrophy with strain may cause long-standing ST depression with evidence of left ventricular hypertrophy. Bundle branch blocks also change the ST segment configuration and will be saved for the advanced course. And now we have the T wave. This represents ventricular repolarization, which is when the ventricles reset electrical activity and prepare for the next cycle. The T wave should be normally a gentle, rounded wave. At times, T waves can be peaked, which usually is the sign of electrolyte imbalance, especially hyperkalemia. At times, the T waves may be absent or flat, which may be a sign of hypokalemia. T wave inversions are usually seen in the setting of ischemia. There are multiple other reasons for T wave changes. Most importantly to note is that T wave inversions are less specific than some of the other findings and do have a broader differential diagnosis. So we have just gone over the PQRST complex. Feel free to go back, review, as the Next set of slides will require you to have a strong knowledge of the PQRST complex. Let us look at the different types of variations of the QRS complex. The first one, the arrow is pointing towards a Q wave. This is the first negative deflection after the P wave and may or may not appear in all complexes. Let us look at the arrow in this slide showing the S wave. S wave is the negative deflection following the R wave. It again may or may not be present in the complex. In some ECGs, the QRS complex may have both the Q and the S wave as shown on the third graphic. On the fourth graphic here, we see an RSR prime pattern, usually seen with right bundle branch block. Here what you're seeing is a small R wave followed by a taller R wave. There is no Q wave in this complex. In the fifth graphic, it shows that there is no Q wave, there is a single R wave, there is no S wave. This is called a monophasic QRS complex. Lastly, there could be a single negative wave absent R wave. This would be called a Q wave, and the complex is called a QS complex and usually signifies infarction that has happened in the past. So take some time to familiarize yourself between the different variations of the QRS complex. These are common variations, but do not include all the variations you might come across. Let us talk about sinus rhythms. For us to call that the patient is in sinus rhythm, the ECG should show a clear P wave, which is uniformly connected to the QRS complex with no significant variation. The first type of sinus rhythm is normal sinus rhythm. In this rhythm, the SA node initiates the electrical impulse, leading to a regular rhythmic contraction of the heart. The rate is usually between 60 to 100 beats per minute, and all components of the QRST are present and regular. Then we can have a slow rhythm, which is called sinus bradycardia. Brady means slow. In this rhythm, everything looks normal, just like the normal sinus rhythm, but the heart rate is less than 60 beats per minute. It is common in athletes, but could indicate other issues. Next up is if the rate is fast. It is called sinus tachycardia. We have sinus tachycardia if the heart rate is above 100 beats per minute. Many reasons, including stress, fever, and other stresses on the body. Then we can have rhythms where the R interval looks like sinus but fluctuates naturally during breathing or other non-cardiac factors. Lastly, we can have a sinus pause or sinus arrest. In this rhythm, the SA node fails to initiate an impulse, leading to a pause in the rhythm. This is usually a concerning sign and may likely necessitate further evaluation. To summarize, sinus rhythms are characterized by their origin from the SA node. They can be normal or indicate various conditions based on their rate, regularity, and other factors. Let us look at some of the tracings that show us these sinus rhythms next. You may want to pause the video here and review each of these blocks to go over what different types of sinus rhythms look like, and then restart the video for subsequent sections. So if we see that there is no P wave present, but the QRS is narrow, it gives us a clue that the rhythm is likely non-sinus. There are different types of non-sinus rhythms. It could be a low atrial rhythm, which involves that the rhythm originates from a focus lower than the SA node. The P wave appears inverted, and the atrium might be depolarized in a retrograde fashion. The next one is atrial tachycardia, when the atrium fires at a regular, rapid heart rate and usually originates from outside the SA node. The P wave morphology is slightly different, but looks quite like sinus rhythm. Next is the very common atrial fibrillation, often abbreviated as AF or AFib. It's characterized by disorganized atrial activity leading to irregular ventricular response. The P waves are replaced by erratic electrical oscillations. Next is atrial flutter. Atrial flutter exhibits organized but rapid atrial activity, often seen and called the sawtooth pattern. Typically, the rate of the atrium is 300 beats per minute. Let's go over what do the non-sinus rhythms look like. The first one is the wandering atrial pacemaker. You will see that there is a P wave and a QRS complex in almost all of the PQRS complex that are visible, but the P wave relationship to the QRS complex changes, and how the P wave looks also changes and even becomes inverted in the last three PQRS complex. This signifies that the atrium are the source of the P wave, but it is scattered all over the atrium and is called the wandering atrial pacemaker. The second one shows that the P wave is inverted, has a constant relationship with the QRS complex, and signifies that the atrium are being depolarized retrogradely or from the bottom up, indicating on the ECG with an inverted P wave. The next one is when the heart rate is fast and the P wave looks a little bit odd. It is not the classic sinus P wave where it is uniform and often called atrial tachycardia. This may be hard to differentiate from sinus tachycardia. Atrial fibrillation is the next rhythm strip and one of the most common abnormalities of atrial arrhythmia. Here, the hallmarks are that the RR interval is variable, there are no identifiable P waves, and you see little oscillations, which are the atrial chaotic activity. The next one looks quite odd, which is called atrial flutter. Superficially, it looks as if the RR intervals are quite constant, but that is not a requirement. The key is that there are P waves which show a sawtooth pattern, and this is literally the P wave beating at around 300 beats per minute. The last one is multifocal atrial tachycardia. So one, there is tachycardia. The second is that the P waves are of different morphology. When we see both of these phenomena, we call it multifocal atrial tachycardia. Let us review some of the more complex non-sinus rhythm. The first one here is the AV junctional escape rhythm. This is where the AV junction takes over as the SA node, and hence there is no P wave, and the impulses are properly transmitted to the ventricles, and there is a narrow QRS complex. The relationship between the P and QRS complex is lost. The second one is the accelerated AV junctional rhythm. Again, the rate is the only differentiating feature from the AV junctional escape rhythm, which is usually slow. The accelerated AV junctional rhythm appears exactly the same, but the rate is faster. Then we can also have, as shown in the next pictorial, is the AV junctional tachycardia, reentrant tachycardia, and the AV reentrant tachycardia. This is when we see a narrow fast QRS complex. There is a P wave which may be inverted or buried in the QRS complex, and there is a relationship between the P and the QRS complex, but it is not normal. These are some common rhythms that are the source of symptoms of palpitations for our patients. On this graphic slide, we are getting into some life-threatening rhythms. These are ventricular rhythms and are significant as they require immediate or urgent intervention in most cases. Understanding these rhythms is crucial as they often signal serious cardiac conditions. Proper identification can lead to timely and potentially life-saving treatments. The first one is the ventricular escape rhythm or idioventricular rhythm. Is usually a slow rhythm with a heart rate below 50 beats per minute and originates from the ventricle. This is signified by a wide QRS complex, and it indicates that the pacemaker, the SA node, has failed. This is usually seen in complete heart block. So to summarize, ventricular escape rhythm is a rhythm where the QRS complex is wide. There is no relationship between the P wave and the QRS complex and is commonly seen with complete heart block. The next one is accelerated idioventricular rhythm, seen when the ventricular rate exceeds the sinus rate and takes over as the dominant rhythm. On a surface ECG, one can see a transition from sinus beat, which has a narrow QRS complex, to a ventricular beat which does not have P waves and has a wider QRS complex. So in summary, the giveaway is that you will be able to see some normal sinus waves, and the rhythm changes to a wide QRS complex, which is usually faster than the sinus rhythm that you have seen. The next one, the third rhythm strip, is a scary rhythm strip. You start off with two normal PQRS complex, and then you have a fast, wide QRS complex at a rate of approximately 175 beats per minute. This is called ventricular tachycardia. The giveaway here is that the QRS complex being wide indicate that the rhythm is originating in the ventricles. The tachycardia comes from the heart rate being fast. This could be a stable rhythm, but often it is the precursor to an unstable patient and unstable rhythm and requires quick intervention. Uncommonly, we have seen at times that the patients are brushing their teeth and their rhythm could look like this. So clinical context matters. The next one is called torsade de pointes. In this strip, you see the first beat as a normal sinus rhythm with a slightly widened QRS, and then what appears like ventricular tachycardia, but it seems like that the ECG is twirling upside down as it progresses. Fortunately for this patient, the last beat is a spontaneous reversion to normal sinus rhythm, and this patient did well. This is commonly an unstable rhythm and may require intravenous magnesium. The next strip is almost always a life-threatening rhythm called ventricular flutter. Patients are unstable. They are usually unconscious or just may have lost consciousness and requires immediate defibrillation. As you can see, the QRS is wide, it is irregular, and looks slightly different from the rhythm strip of ventricular tachycardia. The next one is ventricular fibrillation, which, unless intervened, commonly goes into asystole and cardiac death. This requires prompt recognition and early intervention. Now that we have talked about life-threatening ventricular rhythms, we can next turn our attention to some very common and non-life-threatening ventricular beats that we might see. The first one is a PVC or premature ventricular beat. These are some rhythm strips showing premature beats. The first one is actually an atrial premature beat, where if you look at the first three PQRS complexes, they are regular and normal sinus. The fourth one appears prematurely. There is a different relationship between the P wave and the QRS complex. The QRS complex looks quite similar to the ones with normal sinus rhythm. The next one is the AV junctional premature beat. In this, the QRS complex is slightly wide. The first two show sinus rhythm. The third one has no P wave and is just like a premature junctional rhythm. The RR interval is shorter. The absence of P wave signifies that it is a junctional beat. The next strip is one of the most commonly seen extra beat called the PVC. The first three waves indicate a normal PQRS relationship. The fourth beat is premature, it is wide, it is bizarre looking, and is followed by a compensatory pause. These three components of a wide QRS complex that looks bizarre, is premature, and is followed by a compensatory pause signifies that it is a ventricular premature beat, also known as a PVC. Let us have a practice session by reading this ECG to yourself. Include what is the rhythm, what is the rate, what is the AV conduction, IV conduction, is there any ST segment change, are there any signs of chamber hypertrophy or dilatation? Are there any T wave changes? And what would you say in conclusion this ECG shows? So the way I would read this ECG would be the electrocardiogram shows normal sinus rhythm, no significant interventricular conduction defects, no signs of chamber hypertrophy or dilatation, no diagnostic ST segment changes, no pathological Q waves. This is a normal ECG. Let us learn how to recognize bundle branch block. The hallmark of a bundle branch block is that the QRS complex is wide. Let's talk about left bundle branch block. The QRS complex is wide, which is more than 120 milliseconds, equating to 3 small boxes or more. The QRS morphology in lead V1 and V6 is quite important. In V1, you should see a predominantly negative QRS complex, and V6, you should see a predominantly positive QRS complex in the presence of a left bundle branch block. There should be absence of Q waves in patients with left bundle branch block with no previous myocardial infarction. If a Q wave is present in the setting of left bundle branch block, that signifies that the person may have had a previous myocardial infarction. Secondary ST segment changes are often present in the presence of left bundle branch block, making it difficult or almost impossible to recognize active ischemia. Let's focus our attention next to right bundle branch block. Again, the QRS complex would be wide, meaning equal or greater than 120 milliseconds or 3 small boxes. The QRS morphology in V1 should indicate what is called a bunny ear appearance or RSR prime pattern, where the R prime represents the secondary taller R wave. In leads V1, the RSR prime pattern is quite obvious. In V6, one will often find a slurred S wave, which is also wide. Just like left bundle branch block, there are often secondary ST segment changes and making the QRS complex look quite abnormal and striking. In both left and right bundle branch block, there is no disturbance of the P wave and the PR interval unless there is secondary problems other than the bundle branch block, like atrioventricular block or changes in sinus rhythm. So let us read this ECG together. On first glance, the ECG clearly looks abnormal. There is something funny about the QRS complexes, but that is not the way to approach this ECG. Identify the P waves. We can clearly see the P waves most prominently in lead 2. Every P wave is followed by a QRS complex, and every QRS is preceded by a P wave. This signifies that the rhythm is sinus. Given the rate is between 50 to 100, this would be considered normal sinus rhythm. The next focus of attention is the intraventricular conduction. Here we see that the QRS complex is wide. It is almost 4 boxes or slightly more. best visualized in lead V2. As we had discussed earlier, there is an RSR prime or a bunny ear appearance in lead V1 and V2. The bunny ears indicate that there might be interventricular conduction defect, and the pattern suggests that this is a right bundle branch block. We do see an S wave in V6, which is also present in V5. So in summary, what we see is that the atrioventricular conduction is normal, as signified by a normal PR interval. The QRS duration is prolonged, suggesting that there's an intraventricular conduction defect. The morphology of the QRS complex in V1 and V6 signify that this is a right bundle branch block pattern, and hence the reading on the CCG would be normal sinus rhythm with right bundle branch block pattern and non-specific ST segment changes associated with right bundle branch block. Take a moment to look at the CCG and read it for yourself. What the CCG shows to me is that there are clearly identified P waves with a fixed relationship to the QRS complex. Every P wave is followed by a QRS complex, and every QRS complex is preceded by a P wave. This signifies that the rhythm is sinus rhythm. Again, do not be distracted by the obvious abnormality, which is the QRS complex. The QRS complex is wide, it is larger than usual in amplitude. When you measure it, the QRS duration is greater than 3 small boxes, which signifies it is greater than 120 milliseconds. There's monophasic R waves in lead 1, AVL, and V6. The QRS is mostly negative in V1 to V3. ST segment deviation in direction opposite to the main QRS component, and there is no S wave in lead V6. This is the classic pattern of left bundle branch block. Of note, there is ST segment elevation, predominantly seen in V1, V2, and V3. In the presence of left bundle branch block, this does not signify acute infarction, and there are separate criteria to diagnose myocardial infarction in the presence of a left bundle branch block, which will be discussed in the advanced course. I'm hoping that by now you have gotten the hang of recognizing what is a normal looking ECG and what is an abnormal looking ECG. If you approach an ECG systematically, as we will do so when we read this ECG together, you should be able to recognize what is going on with the heart. So let us approach the ECG. Clearly, we can see that there are P waves preceded by every QRS complex, and there is a QRS complex following every P wave. However, there is something different. The PR interval is quite prolonged. If you pay attention to lead 2, it is almost as if it is 2 large boxes long. It should be less than 1 large box. So this signifies that the time it takes from the SA node to the AV node is prolonged. And in this particular ECG would signify first degree heart block. The QRS interval is normal, and hence there is no associated bundle branch block. There is T-wave inversion, which could mean a lot of things and is likely unrelated to the first degree AV block. So in summary, this ECG shows first degree AV block as signified by the prolonged PR interval of two large boxes. There is T-wave inversion in the leads 1, 2, AVL, AVF, V3 to V6. Clinical correlation for the causes of this would be quite important. Second degree AV block. This is a progression from first degree AV block, and there are two types of second degree AV blocks, type 1 and type 2. Type 1 is also called Wenckebach or the Wenckebach phenomena. Usually type 1 second degree AV block is reversible, whereas the type 2 second degree AV block is non-reversible. The location of the block is usually within the AV node for Wenckebach phenomena or type 1, and for type 2 it is below the His bundle. The type 1 AV block or Wenckebach has a heart rate of 40 to 50 beats per minute as compared to type 2, which will have a wider QRS rate of 20 to 30 beats per minute. Type 1 is usually transient, whereas type 2 is permanent and requires an intervention. It is quite rewarding to recognize Wenckebach from other high-degree AV blocks, as Wenckebach does not require much of an intervention other than recognition. Here are some rhythm strips showing Wenckebach phenomena. What happens with Wenckebach phenomena or type 1 second degree AV block is that the PR relationship progressively changes, and then there is the dropped QRS complex, and a P wave is seen in isolation. It is important that the PR segment following the drop P wave is shorter than the previous. So let us take the time to read this ECG together. This ECG shows that there are P waves that are clearly identifiable, but if you look at the rhythm strip at the bottom, there is a different relationship between the P and the QRS complex between the first and the second beat. The PR interval is prolonged progressively between the first and the second beat, and the third P wave has no QRS following the P wave. The PR interval on the third QRS complex is shorter than the PR interval for the second PQRS complex. This ECG is suggestive of type 1 second degree AV block, also called the Wenckebach phenomena. Let us read this one together. The top strip indicates that there are more P waves than QRS complexes. Looking carefully, every QRS complex is preceded by a P wave, but not all P waves are followed by a QRS complex. That is observation number 1. Observation number 2 is that there is a fixed relationship between the P and the QRS complex when a QRS complex follows the P wave. The third observation is that every other beat is dropped and there is no QRS complex. This is suggestive of a second degree AV block. The bottom strip also indicates something similar. However, the QRS complex is wide, suggesting that the AV block is below his bundle and would be considered as type 2 AV block. These are some rhythm strips indicating high-grade AV block. Let us review them together. On all of these rhythm strips, there are more P waves than QRS complexes. There is no fixed relationship between the P waves and the QRS complexes, and the escape rhythm of the ventricles is very regular, indicating that the junction or the ventricle has taken over, driving the rhythm. These are rhythm strips indicating third degree or complete AV block. Let us turn our attention to ST segments. ST segment is the flat line after the QRS complex and before the T wave. The ST segment is measured at what is called the J point or the J60 point. If these points are elevated, there is ST elevation. If they are depressed as compared to the PR segment, they are considered to be ST depression. These signify ischemia if there is ST depression, and myocardial infarction or acute injury if there is ST elevation. ST elevation can also happen in conditions other than myocardial infarction like pericarditis. Let us read this ECG together, again systematically. I know it looks a little blurry, but that is on intention so that you just don't focus on the ST elevation that is quite obvious. Our first point is, do I see P waves regularly and do they have a relationship to the QRS complex? The answer is yes. Every P wave is followed by a QRS complex and every QRS is preceded by a P wave. Next is the QRS complex normal? There are no rabbit ears, there's no widening of the QRS complex, so we can also say that the intraventricular conduction is normal. The ST segment looks abnormal in almost all leads. In lead 1, it is elevated. In lead 2, it is downsloping and depressed. In lead 3, it is downsloping and depressed. In AVR, it is isoelectric, meaning that it is at the same level as the PR segment. In AVL, there is ST elevation. In AVF, there is ST depression. In V1, V2, V3, V4, and V5, there is ST elevation of differing degrees. V6, there is isoelectric ST segment. This is a very abnormal looking ECG. This ECG, unless proven otherwise, is suggestive of acute myocardial infarction, and the patient should be quite sick and requires immediate medical attention. Again, one of those fuzzy ECGs to focus your attention on making a systematic reading rather than looking at the obvious abnormality. Again, every P wave is followed by QRS. Every QRS is preceded by a P wave. The QRS interval is normal. suggesting that the atrioventricular and intraventricular conductions are normal. The ST segments are depressed in lead 1, elevated in lead 2, elevated in lead 3, depressed in AVL, elevated in AVF, and are isoelectric for the most part in the precordial leads V1 to V5. There is slight ST segment depression in lateral leads. This pattern on this ECG is suggestive of acute inferior wall injury or acute inferior wall infarction. Here is another ECG that you should rapidly recognize as being quite abnormal and also requires immediate attention. Again, every P wave is followed by QRS. Every QRS is preceded by P waves. However, the ST segments are quite abnormal. You should be able to recognize by now that lead 2, 3, and AVF are quite abnormal with ST elevation suggesting an inferior wall infarction. Lead V1 and V2 and V3 have marked ST segment depression and are likely suggestive of a true posterior myocardial infarction. And there's also lateral wall infarction with ST elevation or doming in V5 and V6. This person will also be quite sick and requires immediate medical attention, where we call time is muscle, and the more time that goes by without revascularization or reperfusion, there is more myocardial necrosis. Now that we have gone over quite a bit, let us read some of the next few ECGs together systematically. This ECG at the first glance looks abnormal. Systematically, I do not see any P waves that are clearly identifiable, and hence no clear relationship between the P and the QRS complex. The QRS complex is narrow, signifying that there is no bundle branch block. The ST segments show non-specific changes, but still I can see that in lead 2 there is slight ST segment depression, and we can also see slight ST segment depression in V5 and V6. The heart rate is clearly abnormal and around 175 beats per minute. This ECG would be interpreted as narrow complex tachycardia, likely supraventricular tachycardia given that there are no P waves and the QRS is narrow, and hence for a basic reader it would be quite appropriate to call this supraventricular tachycardia with a fast heart rate, and this patient should have quick medical attention. The patient's symptoms would likely be palpitations, dizziness, and lightheadedness. This ECG is also abnormal, similar to the previous one, but let's again review it systematically. Here, we do not see any P waves, and hence no relationship between P and the QRS complex. The QRS complex is wide. It is also irregular, and it is also irregularly irregular. The QRS complex is wide in lead 1, AVL, V1, and there is no S wave in V6. Putting it all together, one could say that the rhythm is not sinus, and given the irregularity, the rhythm is atrial fibrillation. The QRS complex morphology is suggestive of left bundle branch block. So in conclusion, this is an ECG showing atrial fibrillation with left bundle branch block with uncontrolled ventricular response given that the heart rate is fast. This ECG shows the classic pattern which will catch your eye. However, I encourage you to always go systematically and identify that there are too many P waves. There is no fixed relationship between the P waves and QRS complexes. The QRS complex is normal in width. So your interpretation for this cardiogram should be that this patient has atrial flutter with 4:1 conduction with no intraventricular conduction defect and no diagnostic ST segment changes. Here comes another abnormal looking ECG. Let's approach it systematically. Every P wave is followed by a QRS complex. Every QRS complex is preceded by the P wave. The intraventricular interval, the QRS duration, appears slightly wide, but not enough for us to call it a bundle branch block. The PR segment is also normal. The ST segments are mostly normal, but there might be some sagging in V5 and V6. The most prominent abnormality on this cardiogram is how tall the T waves are and how peaked they are. They are quite pointy. In V3, they almost look like a QRS complex. This is an ECG suggesting tenting of the T waves, often seen in hyperkalemia, which is also a medical emergency. The patient may be asymptomatic or may have non-cardiac symptoms. The ECG can be quite helpful in you promptly checking electrolytes. This ECG also looks abnormal. The PR intervals are normal, the QRS duration is normal. However, there's something the matter with the ST segment and the T waves, and there's also a new wave called the U wave. What this ECG shows is shallowly inverted T waves and prominent U waves merging into each other, forming what some people call the lazy waves, along with a prolonged QT-U interval. The U waves are better recognizable in the inferior leads. This patient had a potassium of 1.7, suggestive of hypokalemia causing the ECG changes. This ECG is also quite abnormal. You can barely see the P waves. You can only see them in probably lead 2 and lead 3. There is a very short QT interval, as if there is no ST segment. The intraventricular conduction is slightly prolonged, and there might even be an intraventricular conduction defect, as evident by a little notch in the QRS complex. This patient had hypercalcemia. The short QT interval is a marker of hypercalcemia. This ECG is also abnormal. Systematic reading would reveal that the PR interval is slightly prolonged. The QRS duration is normal. The QT interval is quite prolonged. The T waves are slightly peaked. So in summary, a long QT interval with a delayed onset of T wave is suggestive of hypocalcemia. Here is an ECG of a patient on a treadmill. The patient has normal PR interval, slightly prolonged QRS duration. The most striking feature of this is where the arrow is pointing is ST segment depression. They are horizontal to downsloping and suggestive of inferolateral ischemia, given that the ST segment changes are in lead 2, 3, AVF, V4, V5, and V6. This would be considered a positive stress test. This brings us to the end of this basic fundamental course on ECG. I'm sure this will raise questions in your mind. Please do not hesitate to ask us. Happy learning.